Good evening. This is a subject of controversy, and everyone treats it slightly differently. However, there are established guidelines and peer practice suggested by the British Association of Dermatologists and NICE. I'll first concentrate on diagnosis and assessment of psoriasis as it affects various parts of the body in addition to the skin, and then concentrate on the second part of the presentation, which relates to management, as would be done in the primary and the secondary care. So, without much ado, we'll go on to the first part of and this relates to psoriasis. The guideline had basically arisen in 2017, updated in 2020, and it has now been upgraded in 2023, September as well. So let's go on. What is psoriasis? So this is not an infective, but an autoimmune disorder which leads to inflammatory and systemic features of a skin disease with chronic relapsing remitting course, and this may also involve the nails and the joints. So it's an autoimmune skin disease which affects various parts of the body. So what is the pathology or pathogenesis behind psoriasis? The outer skin layer, the epidermis, has epidermal hyperproliferation very fast, almost 20 times normal, so that the turnover time of cell reduces from 28 days to 4 days. It's therefore multiplying fast and dying fast. The keratin, which constitutes appendages such as nails or various parts of the toughened skin, undergoes abnormal activity, and this results in hyperproliferation leading to scales. This is an evolutionary adaptation. Sorry. In addition, the pathology includes an inflammatory feature of lymphocytic infiltrate on the lesion as well as in the surrounding area. So why are we interested in psoriasis? Because it affects so many people. Generally, international publications suggest that 1 to 3% of world's population has psoriasis, and between 1.3 to 2.2% of UK population have psoriasis. This was calculated in year 2000, ratified in 2017, and updated by the British Association of Dermatologists last month. Psoriasis affects two age bands preferentially, between 20 to 30 years and 50 to 60 years, and that psoriasis is more common in patients under 30. It rarely affects patients less than 8 years of age. There is no gender preference, but the localized pustular psoriasis, which we'll talk about subsequently, is commoner in women. The Caucasian population in Europe, and particularly in the UK, is more affected with psoriasis to the extent of nearly 3%. And there is a positive family history in 40 to 50% of cases. So there are two slides now, which relate to trigger factors which result in psoriasis or accelerate psoriasis or bring out into the open from remission dormant psoriasis. So bacteria such as streptococcal infection lead to guttate psoriasis with plaques, or even erythrodermic psoriasis, which becomes a medical emergency requiring immediate admission and treatment. Some drugs are trigger factors of psoriasis, such as lithium, antimalarials, beta blockers, NSAID, ACE inhibitors, antifungal medications, tetracycline, and penicillin. In this regard, it would be prudent to mention that when steroids are in use on a chronic regular basis, sudden stoppage can result in a rebound phenomenon of generalized pustular psoriasis. So steroids should be weaned off gradually. Excessive exposure to ultraviolet light, which is often beneficial for many skin conditions, can induce a flare-up of psoriasis. Physical injury, including scratching, leads to uninvolved skin surrounding the psoriasis into developing psoriasis. It's not as if something is being planted into the normal skin by breach of the skin integrity, but this does happen in an inexplicable manner, and this is called Keebner's phenomenon. The other triggers could be due to upsurge or reduction of certain hormones. So the incidence of psoriasis is increased during hormonal changes, such as in puberty, postpartum, and menopause. However, observational studies suggest that psoriasis improves during pregnancy. HIV and AIDS result in exacerbation of psoriasis and can trigger a dormant psoriasis into activity. This is presumably due to reduced immunity strength. Psychological stress caused by psoriasis, if occurring for a long period of time, can trigger or exacerbate psoriasis. And this is one aspect in management that we will be concentrating more on. Lifestyle triggers would be smoking, and this is due to pro-inflammatory cytokines. And it's an observational matter to see that pustular psoriasis occur almost exclusively in patients who smoke. Alcohol may trigger by impairing skin barrier, and this is done by reducing immunity of the patient. So, does psoriasis appear as not just a skin condition, but a version involving other parts of the body? So chronic plaque psoriasis, which occurs more on the scalp, and if it is on the face, it is called psoriasis vulgaris. This is the commonest presentation, to the order of 80 to 90% in patients. There is disc-shaped plaques, and surrounding the plaques is a halo caused by vasoconstriction, and this is known as Voronov sign. Localized pustular psoriasis, such as palmoplantar, and this is the second most common presentation. Flexural psoriasis, also known as inverse psoriasis, affects 3 to 7% of Caucasian patients amongst the group of patients identified and diagnosed with psoriasis. It occurs in warm, sweaty areas such as genital, groin, under the folds of the breast, and under a protuberant abdominal fold. Guttate psoriasis is like grapes, bunch of grapes hanging down. 2% of patients, also known as droplet psoriasis or guttate psoriasis, are usually seen after suffering from an acute condition such as COVID-19, a bad attack of flu, or an additional bacterial infection of the throat and the lungs. It can occur in any part of the body, and there are droplet-like raised features measuring 2 millimeter to 1 centimeter in diameter. Then there is erythrodermic psoriasis, which is rare, but it constitutes an emergency and requiring admission. Generalized pustular psoriasis is also rare, and this leads to bacteremia, and untreated it would lead on to septicemia. Nail psoriasis, which affects about 50% of the people suffering from psoriasis, with lifetime incidence of 80 to 90%. It is commoner when the psoriatic arthritis is also present. Please be mindful that in psoriasis, 10% of patients present only with manifestations in the nails. So, what is psoriatic arthritis? This is seronegative, which is rheumatoid arthritis negative, inflammatory arthritis, and affects 30% of people with psoriasis. Observational assessment suggests that a skin lesion develops before joint lesions by 5 to 10 years. Why there is this lag period is inexplicable. And psoriatic arthritis causes inflammatory nighttime pains, rest pains in peripheral joints, and where tendons overlying these joints are attached, causing enthesitis, which shows up on X-rays as localized calcification and erosion. Please be aware that 20% of patients with psoriatic arthritis have no visible skin lesion. Possibly, this would be developing later. What does psoriasis coexist with more often? So it's metabolic syndrome characterized by hypertension, insulin resistance, dyslipidemia, and obesity. Features of coronary artery disease, IBD, and in that, Crohn's is more common than ulcerative colitis. Venous thromboembolism, persistent anxiety and depression, non-melanoma skin cancers. There is dry eye syndrome, lymphomas, cataract, and more incidence of celiac disease. So, what would be the complications of psoriasis? The psychosexual are often ignored. With a lesion, particularly in the context of exposing the body, such as in the swimming pool, on the beaches, or elsewhere where others would note it, results in negative body image, low self-esteem, of being considered dirty or infectious, and this leads to group avoidance, reduction of activities including work, physical effects in relation to complications. Erythrodermic and generalized pustular psoriasis, if it continues for a while, can lead to heart failure, malabsorption, features of sepsis, dehydration, and anemia. It also leads to low self-esteem, poor relationship, and poor sports. Erythrodermic psoriasis is an acute emergency requiring immediate admission and treatment with regard to antibiotics, steroids, fluid balance, and so on. So, what is the prognosis of psoriasis? When it is a plaque psoriasis, a spontaneous remission may occur in 25% of the people suffering from psoriasis over an indeterminate period of time. Droplet or guttate psoriasis is usually self-limiting and resolves with any treatment in about 3 to 4 months. Early onset psoriasis may become more extensive with instability, and this is most often seen in female patients because of hormonal impact. How does one assess psoriasis? So, in history taking, you take note of failure of treatment in the past, duration of symptoms, where the lesions are present, what might be trigger factors in the minds of the patient, and one can assess from the patient's perspective the suffering and scoring therefrom with psoriasis epidemiology screening tool. And if the score in this is more than 3 or 5, then the patient needs to be referred to the consultant dermatologist for further treatment. One should also assess over-the-counter non-therapeutic treatment and its impact. So this is the assessment tool, which I will describe further later on. So further impact of psoriasis on the patient's life and activities of daily living will come from Dermatology Life Quality Index tool, and I'll be describing this as well towards the end. There is cardiovascular risk increased with unresolved psoriasis. The 7-point physician's global assessment tool would also explain what the impression of the diagnostician is with regard to patient suffering. Like the percentage area in the assessment of burns, the proportion of the total body surface as listed here will also help to show to what extent psoriasis has affected a patient. So the dermatological part is through a chart, and once you have actually used a 7-point or 9-point or 10-point, you would be able to record a score. So how does one classify psoriasis? This is in 2 parts. Generalized pustular psoriasis, more like a bacterial infection, and this happens in people more often when there is chronic plaque psoriasis. Localized palmoplantar pustular psoriasis has similar origin. Erythrodermic psoriasis is an emergency caused by bacterial infection, toxemia, fluid loss, and cardiovascular collapse. Chronic plaque psoriasis is usually disc-like lesions with silvery white scales, and it usually shows up on the scalp, behind the ears, trunk, buttocks, periumbilical region, and external surfaces. Looks very unsightly, and this is the reason for low self-esteem. These plaques can coalesce to form larger lesions. Majority are 1 centimeter to several centimeter with geographic shape. Vasoconstriction surrounding the plaque would lead to paleness or halo called the Voronov ring. Scalp psoriasis affects 75 to 90% of people and it's usually seen in chronic plaque variety. There is usually alopecia. Facial psoriasis usually attracts attention quicker, and it may extend to the hairline. And sometimes it is difficult to differentiate it from seborrheic dermatitis, and often these coexist. And the condition is then called sebo psoriasis. Flexural psoriasis affects warm, sweaty, concealed areas. Guttate psoriasis, we have already discussed, will be from 2 millimeter to 1 centimeter with scaly papules. Multiple lesions are seen after an RT or COVID-19 infection. So there's a long list of conditions with which one should differentiate psoriasis from. And so sebderm, tinea infection, onychomycosis, fungal infection, scabies, eczema, and it can also be looking similar to T-cell lymphomas. So how does one manage it? This is in two parts. With erythrodermic psoriasis or pustular psoriasis, admission and urgent treatment with steroids, fluid, and management of cardiovascular collapse and GI tract features. If there is localized pustular psoriasis, patient should be referred to the consultant dermatologist, but whilst waiting for the appointment, advice and guidance should be obtained for interim treatment. Guttate psoriasis, we've mentioned, requires simple management and a non-urgent referral, as it's likely to be self-limiting. With nail psoriasis, nails are kept short, avoiding manicure, avoiding prosthetic nails, and it usually settles down after a while. No treatment is usually required. But if the condition persists, there may be an alternative cause which must be explored. Scalp psoriasis is one of the commonest in presentation, and it benefits from coal tar shampoo, and there are several examples of this, polytar, alpha-cell, and this should be allowed to have contact on the skin and the psoriatic patches for at least 5 minutes or more before washing off the coal tar with benzalkonium shampoo or Dermax. If the plaque is thick and if scales are adherent and thick, then coal tar and salicylic acid as Sepco can be used and washed off with Capasan. Chronic plaque psoriasis over trunk, limbs, and on the scalp. So education, avoiding triggers, topical treatment, and explanation that it may take several weeks to work. Dovobet gel, ointment, calcipotriol, and steroid or instiller foam may be useful. Creams, lotions, and gels are suitable for widespread psoriasis. Ointments are suitable for areas with the scales to soften it. Lotions, solutions, or gels are suitable for hair-bearing areas. For patients with psoriasis, it's important to check for joints. British Association of Dermatologists or Psoriasis Association have published many leaflets without jargons, which are very helpful for patients to manage. So we are nearing the end of the primary care treatment. So the topical treatment is in two parts described here. So initial response should be assessed in a month's time. And if there are no side effects, it's important to emphasize for the patient to continue. If there is poor initial response or worsening, then a different treatment combination may be needed in line with the advice of the dermatologist. There are certain emergency conditions such as pustular psoriasis, erythrodermic psoriasis, or psoriatic arthritis when urgent referral should be made. So, which emollients need to be used? These should be used to reduce scales and itching. Topical steroids should be used for localized psoriasis, and excess can destabilize improvement. Avoiding very potent steroids such as Dermovate and using vitamin D product. Vitamin D preparations are topical retinoids such as tazarotene and any steroid, bearing in mind that the contraindication would be hepatorenal dysfunction. If the scales are substantial, then salicylic acid for scales, dithranol is fairly toxic and should be used in the hospital setting by the specialist. Coal tar and salicylic acid can be used to descale and soften seppo. So the summary of topical treatment would be emollients such as hydromol, ointment in Aveeno, vitamin D preps such as retinoid, tazarotene, salicylic acid 2% scalp lotion, coal tar products such as Polytar, Alphasil, or Dermax, dithranol cream 0.1% gradually increased to 0.5 over 6 weeks period. For plaques, Dovabet cream or Instellar foam might be useful. So, what is the hospital treatment for psoriasis? Topical calcineurin inhibitors such as topical tacrolimus or its substitute such as primacrolimus can be used for a short period of time. Narrowband UVB may be an alternative if combined with Soralin. Systemic therapy for widespread and recurrent unresponsive psoriasis would be methotrexate, cyclosporine, and acitretin. And there are some high-risk areas such as face, genitals, hands, feet, scalp, or flexures. And this should be treated for around 3 months, allowing a break afterwards. Many of these agents are teratogenic. And if psoriasis affects a patient in pregnancy, there should be avoidance of live vaccine because of immunocompromise. There should be flu, influenza, and pneumococcal protection offered. Biological therapy is revolutionizing the final control, although it is very expensive. Anti-tissue necrosing factor agents such as adalimumab, Humira, subcutaneously given, infliximab through IV, or monoclonal antibody ustekinumab is showing good promise. I admit that this is an overloaded presentation, and what I would want to do is to concentrate on a couple of assessment tools. So the first one is the PEST. So of the PEST, these are the areas where plaques or lesions are seen. And if one undertakes this, have you ever had a swollen joint or joints? If it is yes, so each question is allocated 1 mark. And so if the overall score is 3 of the 5 or more than 3, then obviously the patient is suffering considerably and may need more intense treatment. So there are many other tools, and it might be best to access yourself in order to understand the dermatology life quality index tool, pediatric tool, and hopefully this will lead to better understanding of how symptoms of psoriasis and features of psoriasis are affecting a patient in question. So I hope that the overloaded slide has not overwhelmed you and that I may have made some contribution to the ready assessment and management of psoriasis as is seen in primary care. Thank you very much.